My name is Terry Mamounas. I'm the medical director of the Comprehensive Breast Program of Orlando Health UF Health Cancer Center in Orlando, Florida. The majority of patients with early-stage breast cancer present with clinically negative axilla, and those patients can be adequately staged with sentinel lymph node biopsy alone. So the majority of patients with breast cancer do not need an axillary dissection. So sentinel lymph node biopsy alone has been the standard of care when the axilla is clinically negative and the sentinel lymph nodes are negative. But even for patients that have clinically negative axilla and 1 or 2 sentinel lymph nodes are positive at the time of lumpectomy, particularly if they're going to have lumpectomy followed by post-lumpectomy radiation, there is no clinical advantage in performing axillary lymph node dissection in these patients, as it has been shown in the Z11 ACOSOC trial, which is a randomized clinical trial that compared axillary lymph node dissection versus not in patients that had 1 or 2 positive nodes and underwent lumpectomy with the idea of getting postoperative radiation. Now, whether patients with 1 to 2 positive nodes, 1 to 3 positive nodes that undergo mastectomy, whether this needs an axillary dissection or not, is a subject of ongoing clinical trials. But for such patients, other trials have shown that axillary radiation can actually be equally effective as an axillary dissection in controlling the disease in the axilla, but with significant reduction of the morbidity of lymphedema. So most of the patients that have clinically negative axilla clearly don't need an axillary dissection. On the other hand, for patients who present with clinically involved axillary lymph nodes, axillary lymph node dissection remains the standard. However, for those patients, another commonly used approach is to use preoperative or neoadjuvant chemotherapy. And if we can downstage these lymph nodes to become clinically negative, then we can perform sentinel lymph node biopsy after neoadjuvant chemotherapy. And if the sentinel lymph node is negative, then axillary dissection can be avoided. However, in this situation, the sentinel lymph node biopsy has to follow a more stringent approach, which includes mapping with 2 agents for sure, removing at least 2 to 3 sentinel lymph nodes, and perhaps more importantly, identifying and removing the lymph node that has previously been biopsied and showing that it was positive. So for this approach, what we do is we clip the node at the time of original biopsy, then we give the patient neoadjuvant chemotherapy, then we do the sentinel lymph node mapping, removing the sentinel lymph node, and also we can tag the clip node and remove that. And we can do that either with wire techniques or with wireless techniques or with radioisotopes. We can inject into the lymph node to make sure that the lymph node that had the disease is taken out. When you do that, something that we now call targeted axillary lymph node dissection, then the false negative rate of sentinel lymph node biopsy drops to about 2 to 3%, which is very acceptable. It's actually even a little bit less than the original studies of sentinel lymph node biopsy. So with that approach, we can even avoid axillary dissection for patients that present with positive lymph nodes that would have required axillary dissection otherwise.